Well, good morning, everybody. Thank you for attending our October Public Health Nursing webinar. And I'm glad to see we've got quite a few people have signed up today. I know this is CATA retreat, so a lot of people are out. And so we're still very excited to go ahead and continue this. I'm also excited to say that we are just about ready to post the position of the Chief Nursing Officer. So I will be thrilled, not only so that we can have someone who is much more skilled at this than me doing this, but to give the dedicated time that it deserves. So we're hoping that by next year we'll be back getting our nursing CMEs and we'll have that in place. Unfortunately, I like to tell people that we didn't have time for CME because we were getting all the new and latest cutting edge information out there, and so we didn't have time to get the CME, because that sounds better than I just ran out of time, but that's kind of what happened. I did run out of time. So before we get started with the first presentation on ending the HIV epidemic, I want to say two things. Number one, you got an agenda, but after Elizabeth finishes talking about vaping, we are going to take a break because somehow I wasn't aware that we are having an earthquake drill here in our building at 10:17. I believe this may be statewide, but so at 10:17 we will take a break long enough for whatever we're supposed to do, get under heavy furniture to try to simulate an earthquake, and then we will come back on. So I apologize for that, and not knowing that in advance, I would have incorporated it into the agenda. I would also like Kendall to come up to the screen. So Kendall, you can't see that you're being seen, but Kendall is our new CDC Public Health Associate, and she's a field representative, and I'm going to let her just stand up and say who she is and what she's going to be doing and working, because I think it's important that you see her face, and she can let us know how long she's going to be here. So Kendall, welcome.
Hi, I hope everyone can see me. My name is Kendall Rayburn, and I am the new Public Health Associate here from the CDC. I just got here 3 weeks ago. This is my third day. I'm really excited to be here and do some good work. I come from Atlanta, so I'm about 6 hours away from home, but I'm going to be in Kentucky here for the next 2 years. I'm going to do a lot of work in harm reduction with Jim House, and then also I'm going to do some continuity planning in case in the event of an incident or any accident, we can continue with the day-to-day operations.
Okay, thank you. So you'll be hearing more from her and seeing more from her, but I think this is a great opportunity as we get new employees here in Frankfort, so people can see their faces and hear what they have to say. So, and I came up here without a clock. So is there a clock somewhere?
It's 9:36.
9:36. We are right on schedule. I wanted to take this opportunity to talk to you about the Ending the Epidemic initiative from the CDC. The president in the State of the Union address mentioned that he was going to end HIV in the United States. This is all coming from the fact that the new director of the CDC has done his life work and research in HIV. So he sees this as a time and an opportunity for us to do something. I'd like a cyber show of hands of how many people out there remember before HIV. I certainly do. I was in medical school in the early 80s and then into my residency into the late 80s when we were first hearing about this and being very confused. The things that we did with patients is kind of frightening when I think about it because of the lengths of isolation and the ways that we treated people, because we truly did not understand what we were dealing with. So I've seen that evolution of HIV being a scary death sentence to now, when you look at our annual HIV report that our department puts out from the HIV program, there's not even mention of a whole chapter on death. When I first got here, I expected to see a chapter about the number of people dying from HIV. HIV is a chronic disease now that we can treat with medication. So it's very exciting to me to be a part of this. So I'm going to go through some slides I put together for a presentation in Hazard not too long ago about the epidemic in Kentucky. We can't change the slides. Let me try this.
Click the bottom left, have to go little.
Bottom left.
Yeah.
There you go. Okay. So our epidemic in Kentucky is an epidemic of opioid use disorder, really an epidemic of substance use disorder, because it's not just opioids, and you out there in the field know opioids are taken second tier now to meth. Unfortunately, the meth can be laced with fentanyl, so it still is an opioid use disorder problem. We're also seeing an epidemic of neonatal abstinence syndrome, higher and higher numbers of that in Kentucky and in Appalachia. We have a hepatitis C epidemic that we've had for quite some time, but certainly the substance use disorder and the rise in IV drug use certainly is increasing that. Of interest in 2004, 2004, yes, when they opened the Operation Unite helpline, and people were calling in. Only 1 in 10 people said they were using IV drugs in their drug use situation. And now, last year, 10 out of 10 people that called the United helpline, 10 out of 10 people were using IV drugs. That's where the hepatitis C issue comes in. We also have an epidemic of foster care placement. We have right at 10,000 children in foster care, and a large percentage of those, up past 60%, are because of the opioid crisis and the substance use crisis in our state. What's interesting is if you took any one of those epidemics and threw it into a state and said, fix this, it would overwhelm the system. Right now, we have all of those epidemics going on. So our system is overwhelmed to the 10th power. It is why we all feel like we come in, we work hard, but we still go home and say, did we make a dent? Yes, we are making a dent, and I do want people to understand that. Our deaths have gone down for opioid overdoses, and there's not a one reason for that. It's a combination of naloxone, the syringe service programs, and a whole bunch of things that we're all doing. But what you don't see on this list is an epidemic of HIV. And that's because of the good work people are doing out there in the field. So I wanted to go through and talk about this ending the HIV epidemic so that you're aware of it. It's housed at the CDC, and they are telling us that the goal is they want a 75% reduction in new HIV cases in 5 years and a 90% reduction in 10 years. Since this whole epidemic began back when Connie was a medical student back eons ago in 1981, 700,000 people have died of HIV. 700,000 people. Now, the deaths, as I said, are not what they used to be, but people still, we've had a terrific carnage from this disease. We know that 1.1 Americans are living with HIV today. In Kentucky, that's around 5,000. We have about 360 plus new cases of HIV a year in Kentucky. So we talk about it around here, 1 new person a day that we know of that we are screening and diagnosing have a diagnosis of HIV. The other thing that's concerning in Kentucky is a lot of these folks are diagnosed with HIV and they're in the late stage and soon convert to AIDS. So the goal to try to get earlier screening and earlier detection for earlier treatment is something we're going to talk about. So if we can reduce 75% new cases and 90% in 10 years, instead of 40,000 Americans a year getting HIV, over the next 10 years, that'd be 400,000 more people. We could greatly decrease that number. And there's all kinds of statistical proof that shows that if you can decrease the new cases over that 10-year period of time down to 90%, you're going to get the whole HIV epidemic into something that has got some decent control. On this map, it shows one of the things that the CDC has decided to do is to target their funding, to target this particular project. Rather than going all across the United States, they decided to use a tool and find out where are most of our cases, our new cases of HIV happening. And what they found is that 80% of new cases of HIV, 80% of the new cases of HIV came from 40% of people with HIV. So it's not that everybody that has HIV is spreading it. It's just that there's a small percentage, or 40% of the people with HIV are causing the new cases. So let's go to the areas of the country where the most cases are and start targeting that. And what they found out was that there was around a 70% of the new HIV cases in this country were in these 48 counties that are the dots that you see on this map. Then they looked at rural states and said, what rural states have over 10% of their cases are coming from the rural areas. They have more than 300 plus cases a year. So that's how those 7 states that you see on there were brought into the mix, and Kentucky was one of those states. So we have some tremendous funding opportunities that are coming our way for HIV. Those of you that work in the HIV space know about this. There's a lot of work that we're doing to try to figure out what are some innovative, what are some ways. Ryan White money and all the HIV money in the past has had some tremendous restrictions as to how we can spend it. And this opportunity is going to let us think outside the box. For example, we can help people with if they're living in a home with their housing costs, but we can't help them if they're renting with a home. I may have said that backwards. Now that I said that, that doesn't sound right, but it gives you the idea. We can do one thing, but we can't another. Why can we not help everybody with their housing expenses? And as you know, with social determinants of health, how important that is. So this is going to be very exciting. You're going to hear more about this, and I wanted you to be aware of it. So to end the epidemic, they have 4 strategies that I think are simple and helpful. The first thing, as I said earlier, diagnose people as early as possible. The 40% that are causing 80% of the infections, many of these people are spreading this disease and don't know they even have it. So if we can do more testing, get people earlier, catch them earlier, make sure we don't miss opportunities to catch them with their early diagnosis of HIV. In our cluster outbreak that the Northern Kentucky folks can speak to much better than I can, we know that a tremendous number of the people that were in that cluster outbreak had been to an emergency department or an outpatient department, and no one had tested them for HIV. With the new legislative changes that now allows a physician or a provider in an ER or anywhere to order a test on you, and if it's positive, that physician in the past, that provider in the past was legally required to contact you personally and tell you that you were positive. Now they can delegate that to the infectious disease nurse or someone at the hospital or the facility they work. So we're hoping that will really encourage more providers to check people for HIV, check frequently, check often. And it will also help us, as we're going to talk a little bit later, in the syringe service programs. Their second strategy is to treat people rapidly and effectively to get that viral suppression. We have amazing drugs now, not what we had back in the 90s, which pretty much were not very effective and made people, as I like to say, a medical term is dog sick. We're not having that now. So if we can get these people diagnosed early, get them treated rapidly, and keep them in treatment, then we can definitely suppress those viral loads, and so they're not going to be out causing new infections. If we can prevent transmission through the use of syringe service programs, we had someone from HRSA here recently, Dr. Laura Cheever, who said, I started my work in public health in a syringe service program in Baltimore, and if you told me 20 years ago that I would be out doing a national program promoting syringe service programs, I would not have ever believed it. This is key, and you folks are key out there right now into helping us be sure that patients, when they come into the syringe service programs, when's the last time you had an HIV? We'll throw in hepatitis C at the same time. When's the last time you had that testing? It's time for you to have more testing. You don't have time to do it today. The way we've remodeled REDCap, that will pop up on the screen the next time that person comes in to remind you right at the beginning, ask this person if they will consent to an HIV test today. The other thing that's important for you to know, and you're going to be hearing about this soon, we're going to be having a webinar really soon with Cabell County in West Virginia. We know that Huntington, West Virginia is having a large number of HIV patients, and we want to talk with our syringe service programs. How can we get that message across to our patients, and what other populations besides syringe service programs do we need to be talking to about this? We don't want to wake up one morning and say, hey, we knew that was happening in Huntington, but we didn't take any extra precautions here on Kentucky soil. And then responding quickly to HIV outbreaks as they happen. We did that in Northern Kentucky. One of the new grants we're writing is we're going to write for some staff that are DIS as well as linkage navigators, but to also be trained to be part of an outbreak team. So if we do have some type of an outbreak, we've got people already trained that they can go right into the area and provide the support that locals would need for an outbreak. So diagnose early, treat rapidly and effectively to suppress viral load. use our syringe service programs to the fullest, and then to quickly respond if there's any kind of outbreak, so we can nip that in the bud, to quote Barney Fife, and make sure that our patients in our communities are safe. Okay, so now I'm going to turn the program over to Elizabeth. Elizabeth Hoagland is a part of our chronic disease program, and she is going to talk to you about vaping.
Thank you very much. Good morning, everyone. This is Elizabeth Anderson Hoagland. I'm in the chronic disease branch in the health promotion program. And I'm going to talk a little bit about the lung injury associated with vaping. And I'm going to be the last speaker until the earthquake drill. So that's how we'll know I'm going to stop talking. So I have a lot of things on here, but I promise I'm going to go through it very quickly. We're going to talk about background, about the National and Kentucky statistics, the case definition, how to report potential cases to the state, resources available, treatment, and then some additional resources as well. So as a background, this really got started back in July of 2019. 2 states started a joint investigation, and really there were some hospitals that were getting young people with lung injury in the hospitals. They all had a history of vaping. And so those hospitals contacted those states' departments of public health and said something weird is going on. So they started looking into this back in July. They reported 86 interviewed patients. And of those 86 patients, they had 234 unique types of e-cigarette or vaping product with 87 different brand names. And if we're looking at all of the people who are ill so far, there's been, I think, an average of 2.1 products per patient. So we're looking at people who are using a variety of products. Among the people where they had tested their e-cigarettes that had THC-containing products, and please don't ask me to say THC, what it really stands for, but the psychoactive ingredient marijuana, 89% were from informal sources, as you would in states where it's not legal, and then some were bought at out-of-state dispensaries, online, or from a vape or tobacco shop. So this is, that was back in July. This is where we are as of October 8th, 2019. The CDC updates their website every Thursday, so look for this to be updated later today. We currently have 1,299 cases in 49 states, the District of Columbia, and the U.S. Virgin Islands. The only state not reporting cases right now is Alaska, which, as you know, Alaska's kind of a trek, so that's probably why. And if you look, they have started charting their epidemiological curve. You notice it kind of looks like it's going down. We don't know if that means that we are getting fewer cases or if that's just a lag in reporting. And when I talk about reporting, you're going to see why there's kind of a lag time there. Nationally right now, there have been 26 deaths in 21 states. You can see the states there. A couple of states have had multiple deaths. The median age of people who have passed away is 49 years, but that age range has been from 17 years to 75 years. Based on the patient statistics, 70% are male, 80% are under 35 years old, and looking at, these are people who are using e-cigarette products with nicotine and THC. Those people tend to be younger anyway, so it's not surprising that we're having a patient population that's skewing younger. You can see 15% of patients are under 18 years old. When we look at people who are getting sick, they've reported e-cigarette use in 30 days prior to onset. 76% have used THC-containing products. 32% or a third have only used THC products. They're not using anything else. 58% have used a nicotine-containing product. 13% have only used nicotine-containing products. So what you see is there's a large population that is using both THC and nicotine. There's no single product or substance that has been linked to all cases. So at this point in time, I think what the public really wants to know at this time is tell me what's safe, tell me what I can use. And at this point in time, we cannot guarantee the safety of any particular e-cigarette product. Not that we ever said there was a safe e-cigarette, but at this point in time, we can especially say we can't guarantee the safety of any of these products. And the specific chemical associated with the lung injury is unknown. Our numbers are from October 11th, 2019. Look for these to be updated tomorrow on our website, which I'm going to show you in a second. We have had 28 patients reported to us for investigation. 1 of those cases is confirmed, 6 are probable, and 3 have been ruled out as cases. And so what does that mean? That means we went through the medical history, and by me, I mean actually a pulmonologist, not me personally. And they have looked through and they said this person either doesn't have a documented history of vaping or that person does not meet the case definition. It's kind of a complicated case definition. If you really want to see our updated numbers, I encourage you to look at our website, and I do apologize, our website's kind of difficult to navigate, but I have a screenshot here. If you go to the Cabinet website and just search for severe lung injury and vaping, that'll come up. You also see at the bottom we have the link, and when we email this out, you can find the link. Our updated numbers are always going to be on the right-hand side of the page in green over here. So what is happening when people are coming in sick? Most patients are young and healthy. We've looked to see if there's like history of asthma in the family or a personal history of asthma, nothing like that. Most of them are young, most of them are healthy. They report a gradual onset of various symptoms over days to week, and it's some odd symptoms as well. So of course there's respiratory symptoms like cough, chest pain, shortness of breath. You put a pulse oximeter on them, you see they have low oxygen saturation. Something like 70% of patients also have gastrointestinal symptoms like abdominal pain, nausea, vomiting, diarrhea. We're not sure why. The gastrointestinal symptoms tend to clear up once the people are in the hospital fairly quickly. We don't know what's causing that. I mean, obviously we don't know what's causing anything, but we're really not sure why that's happening. And then there's systemic symptoms like fatigue, fever, and weight loss. We had someone whose medical records we're looking at and they lost 49 pounds. So like severe weight loss. Sometimes the GI symptoms come before the respiratory symptoms. Again, we're not really sure why. And then almost all the published cases have been hospitalized. And I think what's important to say here is that, you know, obviously these people are getting sick, they're getting very sick. And so a lot of the people we've looked at have had multiple contacts with healthcare providers. And sometimes they've ended up in the hospital more than once. They've been discharged, they've ended up back in the hospital, or they'll see an out-of-patient clinic before going to a hospital. So for those of you who are working in the public and keep in mind that if someone has a history of vaping any product and they're starting to show any of these symptoms, it could be a sign that they're in the early stages of disease. Upon presenting to hospital, of course, it's pretty much what we saw before: fever, respiratory symptoms, tachycardia, tachypnea, I'm not even going to try to say that, hypoxemia. Dr. White knows how to say that. And so you can see even people who did not report respiratory symptoms still had low oxygen saturation. So even if they weren't noticing something going on, they had something going on. If you look at the laboratory and the chest imaging, really when we get to the case definition, you'll see the abnormal symptoms are really looking at ground glass opacities on a CT of the chest, or subpleural sparing when you look on an X-ray. As you can see, you know, these people are sick, but there's nothing that's really definitive. We've had a couple of cases from other states that have been diagnosed as lipoid pneumonia, but that's not consistent with all of the cases across the country. The spectrum of clinical and pathological diagnoses, when we first started looking at this, we called it acute lung injury and adult respiratory distress syndrome, but that's not necessarily what's going on. Diffuse alveolar damage, lipoid pneumonia, acute necrotizing pneumonitis, other types of organizing pneumonia with lipid-laden macrophages, inflammation, pneumonia. There's been a variety in the spectrum of diagnoses. And something the CDC and the FDA have said in the past week is it's possible that we're looking at several different actual diseases with several different causes. And if that's what's going on, then this is going to be a really complicated investigation because we're not looking at one disease and one causative agent, we're looking at multiple. This is the official case definition for a confirmed case. It's someone who's been using an e-cigarette 90 days prior to symptom onset. Pulmonary infiltrate, such as opacities on plain film chest radiography or ground glass opacities in the chest CT. There has to be an absence of pulmonary infection on initial workup. especially as we're going into flu season. Of course, the early stages of all diseases kind of look like, you know, the early stages of flu, but it's going to be difficult if someone comes in with a vaping history. You really need to make sure you do that viral influenza panel to make sure that that's not what's going on. And then there's no evidence of an alternative plausible diagnosis. So for a probable case, again, using the e-cigarette, they have the opacities and a CT scan, and they have done a PCR panel. They've looked at some infectious disease etiologies. There might be something else going on, but the clinician team believes that the vaping is the primary cause of illness. And that's the difference between a confirmed case and a probable case. If you're working with a healthcare provider and you have someone come in and you're like, well, this person really meets that previous case definition, what do we do? We're asking them to report to the state using the EPID 200 report form, which is meant for reportable diseases, but we're making it work. For the illness name, list it as a vaping lung injury and report via secure fax like you would for any other reportable diseases. The person who's kind of our general point of contact is Mel Grissom. His email address is there. You note it says George. He goes by Mel. And then we have that website, our general information website is available there. For clinicians who need more information than I'm able to provide you, because clearly I am not a clinician, the CDC has extensive information on their website. They have a section specifically for healthcare providers. If you, I know some health departments are working with their local hospitals to collect biological specimens or vaping materials. All of that can be sent to our state lab because the state lab is collecting that before we turn that over to the CDC or the FDA for further testing. So if you just happen to go to the Division of Laboratory Services website, you'll see that there, but we also have the link available here. And we also have our general tobacco prevention and cessation website available. For people who have gotten sick, again, since we don't really know what's going on, we're not 100% sure how to treat that. You know, people don't really get better with or without antibiotics. Of course, supportive therapy, making sure people get oxygen. People have been on ventilators. There have been people, a lot of patients who have responded to corticosteroids. So that is a possible solution, but again, it really depends on the person who's sick because steroids can have other types of adverse side effects that you don't want to, you don't necessarily want to cause to someone who's really sick. And then again, just really emphasizing you need to test these people for influenza as well. Just because someone has vaping and they have have some kind of lung symptoms, that doesn't mean that it's not influenza. And that doesn't mean that someone can't have a lung injury from vaping and influenza. So making sure that we treat those people especially carefully. For outcomes, the CDC right now is really recommending that people have a follow-up inpatient, a follow-up visit 1 to 2 weeks after discharge. We are seeing people who are ending up back in the hospital. We're seeing people who are on long-term oxygen. So it's really important to have that follow-up visit just to make sure that everything is still working the way it's supposed to be working, that something isn't going wrong that wasn't noticed upon discharge. And I think something again is that with e-cigarettes, when we're working with nicotine or THC, those are both addictive substances. So this is not just, this isn't something like flu where you catch it. This also has a behavioral component. I'm going to talk about that in a few minutes. So what information should you give patients? Of course, at no point have we recommended vaping from the Department for Public Health, but especially right now, do not use e-cigarettes if you are a youth or a young adult, if you are nicotine naive, meaning you've never used nicotine before, pregnant women, adults who have not used tobacco products. If you do use e-cigarettes, please don't buy them off the streets or through informal sources. Do not modify your e-cigarette. You know, just looking at the liquids people are using, a lot of them have fungal or bacterial contamination anyway, because they're not necessarily made in sterile laboratories. Anyone who does use e-cigarettes, continues to use e-cigarettes, needs to monitor themselves for symptoms, and if they have any concerns, to promptly seek medical care. Because when people get sick, they get sick really, really quickly. If you work with people who are trying to quit smoking and they say, well, I'm thinking about using e-cigarettes, please refer them to FDA-approved treatments. such as counseling from a healthcare provider and FDA-approved medications, nicotine replacement therapy. We all know what the side effects of those are, and none of them have caused people to end up in the hospital at 17 years old with a chest tube. For people who use nicotine and are looking to quit, they can go to quitnowkentucky.org, text QUIT-KY to 797979, or go to call 1-800-QUIT-NOW. We have free cessation help. And anyone who is uninsured or on Medicare can get free nicotine replacement therapy through our Quit line. They can also get it through, if they have health insurance, they can get it through their health insurance provider. For people who are using marijuana or THC, I know THC and marijuana especially has a reputation for not being very addictive, but keep in mind this is a new era with THC products. We're having 70–80% THC in these e-liquids that people are vaping, and they're not using it on a Friday night at a party. They're using it continuously through the course of the day. These people are using a lot of THC. So I would say that a little extra help would be appropriate. So in Kentucky, we have findhelpnowky.org. You can text HOPE to 96714 or call 1-833-8KY-HELP. And from our Division of Behavioral Health, what they recommend interventions such as cognitive behavior therapy, contingency management, motivational enhancement therapy, and multidimensional family therapy have demonstrated efficacy in the treatment of individuals who report problematic use of THC or nicotine-containing products. And so at this point in time, especially if someone is starting to get sick, they might need help getting off of the THC products. I'm really nervous about time right now. You don't want to see me duck and cover.
You've got 10 minutes.
Oh, well, I just flew through that, didn't I? Okay, so here's my contact information. We are going to send the slides out because we had a lot of links in there. So if you have any questions, you can go ahead and contact me. Oh, okay, yeah.
What about CBD oil, which is different than THC? So
yes,
if people want to use that in their cartridge.
There have been patients who have gotten sick using CBD oil. So at this point in time, there is no single product that has been associated with all forms of illness, and we cannot guarantee the safety of any product. It is probably not inherent to the nicotine or the THC or the CBD, or we'd be seeing it in all of those products much more broadly. It is probably some ingredient that is being used in the e-cigarette products, and it's just made it more in the THC products than it has the nicotine ones. They're having a great time next door. They're really looking
Somebody's
forward.
having a
Oh, it's dope. Okay.
I know that there was a report of some early 20s that year-olds brothers in their basement in Wisconsin that were just putting together cartridges in the basement, and they arrested them, and they're in some significant trouble. But I think just putting anything in there. I think one of the points that Dr. Derringer, our new commissioner, made in the presentation I saw her give was the difference between vapor and aerosol. And I think we probably, as public health, shouldn't have let them get by with the word vaping in the beginning, because vapor to me is when I was a kid, and mother put Vicks vapor up on my chest, and I had a blanket over my head and breathed in steam.
Mm-hmm.
And this is not steam. This is small particles of oil that go into the lung. Before we hired a pulmonologist specialist to look at this, I was doing some of the chart reviews, and they were truly frightening of how sick these people got so quickly. And one request we have of everyone out there is we are getting all kinds of articles that people are sending us from their local newspaper, local high school track star in the hospital with the chest tube. We don't have that EPID 200. So if you can really encourage your healthcare providers, we know that the numbers that we're looking at are smaller than what's really happening. Mm-hmm. So we really do need your help to help us get those charts here. We've got a question, and I'm in my reading glasses here. So what does it say?
Do you have any information that we can share with schools to talk about the harmful effects of vaping? We have a lot of information about that. I would recommend you go to our General Tobacco Prevention and Cessation website, because we have a lot of that information posted there, and that will be on the handouts. Off the top of my head, probably my favorite resource is the Stanford Tobacco Prevention Toolkit, which is out of Stanford University. They also have a marijuana component because they're based out of California. Both of those would be very appropriate right now. It is a free resource that any community organization can use. It's especially great for schools because it's all put together and easy for them to implement. As we're talking about specifically about this lung injury, we're still working on communications like that.
Okay.
Is it time to duck and cover?
It is almost time to duck and cover. We still have a few minutes. I wanted to be sure that everyone knew that we will be put, as we have before, EWD, our Education Development Workforce. I get that wrong?
Education and Workforce Development.
Okay, I always get the letters backwards. I know a lot of letters in my head. They just aren't always in the right order. We have been able to, usually by next week, we will have the audio version of this webinar on the nursing office website, and then we will also have all the PowerPoints. What we might want to do, Elizabeth, is that Stanford program you're talking about, we'll also add the link to that so that way if you have trouble finding that or you want to go back and look at that, but we'll put that also on the website. We'll get that to Deb and put that on the website so everybody will have access to that. You know that somebody's already invented this, so let's don't reinvent that. Yeah, the CDC has got a tremendous number. I talked to Elizabeth this morning when I was typing up the agenda, or whatever day I did that. I wasn't sure about all of her credentials, and I looked back at our past webinars, and we actually had Elizabeth here in June. And we had invited Elizabeth just to talk about vaping because it was new, it was something that we were seeing more of. So that was a vaping talk about what is vaping, and this is a vaping talk about it's killing people. Yeah. As a physician, my worry is you've got a 17-year-old that has had all these things happen to them. What are their lungs going to be like forever, for the rest of their life? How much trauma is that lung going to be able to take when they get to be 60 years old? We obviously don't know that, but I think we've got some long-term issues that we're going to be dealing with. So thank you very much. Yes, a question for us.
So have you guys noticed, like with the data, are people who've never used like cigarettes or tobacco products before now vaping because it's on like trend? Like I feel like vaping came out so that people could not smoke cigarettes and get off of that, and it was looked at as like a healthier alternative to cigarettes. But now are people just vaping who never previously used those products?
You want to step up here and repeat
Sure.
the question and answer that?
So the question is, looking at people who use e-cigarettes, are most of them previous smokers who are trying to transition to another product, or are they younger people who have started using e-cigarettes without any previous history of tobacco use? And the answer is the latter. Most people who use e-cigarettes have never smoked before. Most of them are younger, under the age of 30, and they initiated by using e-cigarettes. If you look at adult smokers, a lot of adult smokers have tried e-cigarettes. Very few of them stick with e-cigarettes. E-cigarettes, even the best e-cigarette, does not give a nicotine hit the same way that a cigarette does. So people who are trying to maintain that addiction, an e-cigarette just isn't as satisfying as a cigarette, or they'll become dual users. So they'll use an e-cigarette where they think they can get away with it, like an office building or in their homes, and then they'll smoke when they're outside. So the vast majority of people who use e-cigarettes are younger people who have not used a previous tobacco product. Now, if you listen to the ads, they make it seem like e-cigarettes are a cessation device, and that's just the advertising. They're not allowed to say they're a cessation device because they haven't been FDA approved as a cessation device, and no e-cigarette company has gone through the process of proving their effectiveness as a cessation device. That is merely a marketing ploy so that they can continue to operate in our communities without getting called on their bad behavior.
Well, there you go. Hey, welcome everybody. We're ready to get started now. Thank you for that brief interruption. Do I have the dates for the DP8 Public Health Nursing in 2020? Our clerk is working on schedules. That's a great idea, and I will write that down. Deb is not here today, but I know Deb will be on it. So we will send those out, and we'll also post them on the nursing office website. Okay, next we're going to go to Benita Decker. Benita is the family planning coordinator Adolescent Health Program Director, and she's going to talk to you about some changes. The NEC has approved these changes, and we have not gotten them out to you yet, but we're going to get these changes out. And one of the things she's going to be talking about has to do with sexual involvement of adolescents. We are going to have in December, we're going to have a presentation just on that and what are your requirements as a nurse in a health department setting of reporting when you have someone who is having sexual relations with someone who is clearly older than her, or a question of is there coercion going on. So we'll let Benita talk about the changes to the CSG today, and then stay tuned in December because we will have a presentation on that then. So I'll turn it over to Benita. Thank you.
Okay. Thank you, Dr. White. There is some, we're just learning about them too, some minor but significant changes to mandatory reporting and criminal reporting. And so I'm excited that in December, there's going to be a presentation on that. We were also working on clearly updating our stuff too, so that you'll have that. It's still in the works. First, before I get started, I want to introduce, I don't think, I'm not on camera. They just see the slides, right?
You're on camera.
I'm on camera. Hello, everybody. I love being on camera. But I want to introduce Sheila Rose. Sheila, come wave to the camera. We're not on the camera here, so that's probably a good thing. But yeah, Sheila is our new family planning nurse consultant. Sheila came in July, on July 15th. She came from the Anderson County Health Department. She has already been my right hand in so many ways. In just 3 months, I have just baptized her by fire into the family planning program, and as you're about to see, and I really am glad. So when I'm not available, you can always email Sheila at sheilag.rose@ky.gov. Do you want to say anything?
No, I'm just excited to be here, and it's a new day, and I'm glad that I get to be on board at the beginning of this.
Yeah, it's a new day. So thank you, Sheila. So she's here to hear all this. There are lots of things going on with family planning. For those of you who are not taking family planning dollars, those few that aren't taking any family planning dollars, there are 10 health departments that did not take family planning dollars this year. I'm sorry you have to listen to this because it doesn't. But you are, yeah, you do need to be informed. You know, you never know what tomorrow will bring. Okay, I'm not moving.
It's the little bottom left button.
Down
What did you?
there. No, do with your clicker.
Sorry, guys, a little technical this part. Okay, so why are we doing this? Well, here's the situation. And I'm going to read this, but I want you to see it. The Office of Population Affairs, OPA, released the final ruling on July 15, 2019. It's been in the news a lot, maybe not so much in Kentucky, but it's very big national news. This ruling significantly changed several of the federal regulations related to family planning requirements. These are federal laws that we're about to talk about that have been put into place. OPA is requiring that these changes be implemented immediately. In fact, we're just a tiny bit behind, taking into account the change process required by each organization. So they are aware that it takes a while, especially for states. There's Title X grantees are not only state government grantees, but also smaller organizations. So those guys, they're like, hey, why aren't you doing this? For the states, they're giving us time because they know how it works and the process for approval and everything is in a state. But meanwhile, we're moving on. And I just got an email this week. They want to know when we're implementing these rules. They're really on it. And also so because of this, the other reason that we've got to take care of these changes is because of public health transformation. It has changed the way that family planning is being done in a lot of local health departments. And so I needed to address that in the AR and the CSG so that you all would know if you're a health department now that's only doing pregnancy testing and STD testing and maybe emergency contraception. You need to know how that affects you as compared to those of you, which is about half of you, are doing family planning as we've always done it, by providing complete access to care through our health department. And it's okay. I don't want you all to hear any judgment calls, okay? It's really important that you know that. It's a new day, and life has changed with public health transformation. And so we want to make sure we're taking care of each individual health department in the way that they need to be taken care of. And as we always say, when you see one health department, you've seen one health department. And so, but we have to provide some regulations and some guidance that can help all of you. So, there's going to be pieces in this for everybody. So in response to this, as I've said, we've revised the AR and the CSG to reflect these changes, and also to reflect what's going on with public health transformation. So I'm going to go through the AR first. There's some of the pieces that have changed in the CSG, which we're going to do second, we've reflected in the AR. So what we've done is the family planning program description has completely been rewritten to address the new issues in public health transformation and the new rulings. Now, but there's also the family planning requirements. Many of them are all the same, okay? Now, the revision to the AR is still in the approval process with LHO, but hopefully we'll have that out soon. If you want a copy of that in a draft form, just email me or Sheila, and we'll be glad to send it to you. Don't think there'll be any problem, but it's just a process. And so what I want to do is I want to go through the AR changes that have happened. So I'm not going to go through every piece of the AR. A lot of it's the same. I&E committee's the same, and everything else is this. I mean, there's a lot of things, voluntary, part of the program, the sterilization stuff. There's just a lot of stuff the same. But I'm going to go through the changes, okay? And then also some of these changes are going to be in the AR. We're going to discuss at the CSG part, okay? So what we've done is I reformatted our section of the AR, and it starts out with a synopsis of the federal new rulings, and then guidance to local, and then it talks about guidance to local health departments about what to do if you're going to actually keep doing family planning, taking all your Title X funds, only taking a partial or not taking them at all. There's some guidance there about that. And then I break the Title X requirements into two sections. The first section of the document will talk about what all subrecipients of Title X funds, and what you have to do if you even get $1 of Title X funds. And then there's specific program guidance for all the different services provided under family planning based on what your health department is doing. Because, family planning is, of course, contraceptive services, but it's also STD testing, it's pregnancy testing, it's preconception health care and counseling, it is basic infertility counseling, that kind of thing. So a lot of that was already in the AR, but just kind of discombobulated. They weren't connected anyway. So I'm hoping that you'll find that this is a better format as you read through the AR. Okay, so let's talk about that first section, okay, and what you may see that you haven't seen before. First of all, that first section is required of all Title X subrecipients, regardless of the extent of their family planning services. Now you're thinking, well, I thought we always had to provide it all. You did, but a part of that law that changed was that broad, provide all contraceptive services went away. And so subrecipients can, to some extent, pick and choose what they want to do in the family planning world. And so that's allowed us to be a little more lenient in how we are dealing with our health departments. Okay, and so it includes, that section includes all the requirements provided in the federal law for Title X, and most of the information has not changed, I've said, okay? Updated requirements are not already discussed in CSG, as we're going to talk about personnel requirements. They revised the language and training requirements. I know our training calendar has been out of commission for probably 2 years now. It is no longer out of commission, it's completely changed. So in just a few minutes, we'll talk about that, okay? So I talked to you about what family planning services are, and that's what that second section does, is specific guidance. And then the very end of our AR section is something that is good. It's mandated by DPH, and it should be. I've listed all those legislative mandates. I didn't list them because it would take in pages, but I've listed a broad definition of them, and also some state regulations, but then I provided you the links to those so that you can just click right to them and look at the OPA website and other sites that can show you, okay, is Benita really know it? Is she making us do more than what's required, which I promise I'm not. And so you can have access to those laws. And so that's provided at the very end of the document, the family planning program section. Okay, So that's what the thing is, okay? But we do have a new family planning requirements. Calendar is out of we've knocked that word out. Here is what the new family planning training requirements are. I'm gonna go in sections. This is training requirements for all staff who touch the patient, who come in contact with a family planning client. So this includes, APRNs, I didn't say that, but RNs, LPNs, clinical support personnel, and clerical staff. Anyone who's going to have an encounter and talk to the patient needs to have these trainings, okay? First at orientation when they're a new employee, or if you hadn't caught up. There's an abuse, neglect, and violence section in the AR. We've turned that into a handbook. And so instead of doing like 3 hours of mandatory reporting that you may or may not remember, we have that available now as a handbook with a cover page that a patient, an employee will sign. That employee and their orientation has to read through that handbook. They will keep that abuse, neglect, and violence handbook, and they'll sign an acknowledgement form and give it to the supervisor or the nurse leader to keep in their training records to show that they do have that. Now, of course, we'll update it from time to time, and what that'll, and we'll provide updates as it goes. But the current one is up to date. All the phone numbers and all, it's a thick handbook. It has phone numbers and resources. I suggest that you keep one at the nurse's station if you don't already, because we really want to start really thinking about how much we are watching out for things like human trafficking, abuse, and neglect. And so this is going to be a better way. I think we need to do that. So they have to read that whole handbook and then sign a page saying, acknowledging that they've read it and that they will comply with the laws within it. Okay, so that has to happen when they're a new person. There's also a new slide deck called Introduction to Cultural Competency. This is a slide deck they'll just read through, or you can present at a staff meeting. It's however you want to do it. We will provide that to you. Just call me or Sheila or email us, and we'll send those to you. We're going to send them out once it's probably after November 1st for you to have. And then you will just, or that employee can just, get on that PowerPoint and read through every slide and talk. And it talks about, it's an introduction to cultural competency, really covers a broad range of stuff. I put that it'll take about an hour for both of these. It probably will take less, but it gives you them a time to just absorb and be as culturally, get an introduction of what being culturally competent is. These two courses only have to be done at orientation. If you as a supervisor and as an administrator want them to have this more often, you're more than welcome to do that. But we only require this at orientation. The next thing I want to talk about is what's the courses that are required at orientation and then every 3 years. The 3-year part is because our grant cycle runs 3 years. These are things OPA strongly recommends that we do. So there's a Title X orientation course on the National Family Planning website, Training Center website. It takes about an hour, and we want every employee to read that, to know why they're having to do what they do in response to the grant. Okay, so it's a good orientation. The most it's going to take is an hour, and then the second one that you all have to do all your employees have to do every 3 years. And at the beginning is Family Planning Basics. It's also on the National Family Planning Family Planning National Training Center website. Many of you have already done that. That has to be done at orientation for new employees and every 3 years by all your staff. And it has 2 nursing CEUs. Y'all remember, if you're older, it used to be they charge for those CEUs. They do not anymore. So those are 2 free CEUs. And then the last course that we want you to take from the Family Planning National Training Center is a Counseling Adolescents About Sexual Coercion and Abuse. That is required, and it's been strongly re-emphasized in the new law. And so it takes about an hour and a half to do that module, and you get 1.5 nursing CEUs as a nurse for that. You need to have your employees take that at orientation and every 3 years. Then the last thing that you have to take every year, the only thing you're going to require to take every year, is the annual training of Kentucky state laws regarding mandatory reporting. If you remember, that's been there forever. Those slides have been updated. They may need to be updated again. We're working with the Kentucky Association for Sexual Assault Prevention people because of this adolescent piece. They're not updated in that respect yet because we're still working with them. But right now we'll send that out. It's that slide deck that takes anywhere from 10, if you're a slow reader, if you're a super slow reader, it'll be 30 minutes. Most people, it takes about 10 to 15 minutes to review that. Those have to be reviewed every year. One, to keep you fresh and remembering what I need to report and what I don't need to report, what I need to be looking for in my clients. So that will be required every year. Again, it'll be a slide deck that we will provide you from the Family Planning Office. And then also there'll be an annual cultural competency course that will be required by everybody, and we will provide that every year. Or you can choose your own and just ask me or Sheila, is this course okay to use for our cultural competency course for the year for our employees? Maybe, you know, you're gonna have a Bridges Out of Poverty course, or you're gonna have something. But we will also provide a course every year on something. This year, coming up, it's going to, because we've never done the introduction to cultural competency, we request that you all just use that orientation introduction to cultural competency as your cultural competency course. And so if you have a problem with that, or you want to do something else, just email Sheila or I, and we will discuss that. And probably if it has anything to do with cultural competency and it's an hour, we'll be there. We'll approve it. Now, one thing we do ask is that if you have a cultural competency course for this year, it can't be one that you've had in the last 3 years. And we want some fresh, there's a lot of items in cultural competency that your staff, we all need. And so don't repeat a course. You need a new course at least every 3 years. And there's all kinds of things, you know, strength-based approach to patients, adolescent health, you know, trauma-informed care, ACE. I mean, there's so many cultural competency things out there. So we will be choosing a course every year to offer you, to suggest for your employees, but you may use your own. And that is the training requirements. That's all. So, so there are no courses on train, okay? All the courses are hardcore. So you know, just on hard copy, just call or email me and Sheila, and the ones that are on the Family Planning National Training Center website, we'll send those to you. Whoever's in charge of your training plan, which is mostly nurse leaders, must keep account for all your employees on their training and make sure that they've got all their training completed. And so there's no accountability on train. The nurse leaders will be the accountable person to make sure their employees are trained when you get your site visits. The 3 hours of family planning CEUs are no longer required. So this is it, and they'll be outlined in the AR. You do not have to worry about finding 3 hours. There's not going to be that long list of 40, 50 courses out there for you to pick from, because you're not required to do that, just the courses we've listed. And that these are going to be effective November 1st. So starting November 1st, the training courses information and electronic copies by then will be sent to you all, and then you will be responsible to get those done. Let me break real quick and make sure, see if there's any questions. Where do we go to access the Abuse, Neglect, and Violence Handbook? Will it be online? Yes. Okay. Actually, you'll go to Sheila and I for that, or you can pick it, you can take it out of the AR, but you're going to have to, the AR has that copy of that chapter. We've just taken that out and added a signature, an acknowledgement page, so your employees can sign a page saying, I have read this and will comply with what's in it. So if you'll just, but we're going to be sending that out. We'll send out that.
Can we, is there a place it could live that we could post it on a website, your website?
We are updating our women's health website, and so as soon as that is updated, we will post it. I guess we could post it on the nursing website. Is that a possibility? We can. We'll post those training materials not on the National Family Planning Training Center, on the nursing website until, and then once women's health is up, we'll put it on both. Are you going to send us this PowerPoint? I can send this PowerPoint out. We can do that, and so you'll have this information. And then also
by next week, the PowerPoint and your audio will be posted on the nurses Nursing Office website.
Okay, so by next week, the audio of this and the PowerPoint will be posted on the Nursing Office website. And then if you want it before then, just email me or Sheila. I'm saying that because after next Tuesday, I'm out of town for 3 weeks. And so out of the office for 3 weeks. And so make sure you've written Sheila's email down, sheilag.rose. She's who you're gonna have to contact while I'm gone. Okay. All right, let's move on. All right, let's talk about CSG or CSG changes. It's hard for me to change that acronym. First of all, I want to give you the good news first, and then we'll talk about some of the challenges. The FP1 and the FP2 consents are gone. We will be removing them from the CSG. They are not required. The FP1 consent for contraception, you don't have to do that anymore. The general consent signed by the client at registration is sufficient. You don't have to do you don't have to have them re-sign every year. If there's an FP1 in your patient's chart, keep it. You don't ever want to destroy a document, but you don't have to have them sign it again. You don't have to have them from this moment forward. You do not have to do an FP1 on any family planning client. So yeah, that's your good news. There's a little more coming. The FP2 consent for depot after 2 years is gone. Yeah, we are going to remove it from the CSG. Please remove it from your forms. It is no longer required. You do need to make sure that you counsel patients on bone density loss, and then make sure that's documented within the medical record. But you don't have to have them sign and say, I know that I may lose bone density. They can just keep taking depot forever. And the reason is, and even though it's still a black box in the guidance from managing contraception, it's almost a gray box because there's even a disclaimer there. Because if a woman goes off of depot within a year, her bone density is within 90 to 100% back to what it was. And so once she goes off depot, even if they've been on it for a long period of time, it returns. So it doesn't have a permanent loss. But you need to counsel them on that, as you always have, but you don't have to have them sign anything. So again, FP1 and FP2 are gone, okay? And I remove consent language wherever, I think I read through them all, from any of the forms, those, instruction forms for you all. I think I removed that language. There is still a consent needed for IUD and implant insertion and removal. And it's because those are invasive procedures. And so if your health department, and hopefully all of you who do family planning contraceptive methods, are either working on that or are providing some kind of long-acting reversible contraceptive, you do need consents for that because, again, it's invasive. All right. The new law has required that we ask the age of the partner for anyone under the age of 18. So the age of the partner is now required to be documented on all minor family planning clients, okay? That's big, red, bold in the new rules, okay? Note, if the minor is not a family planning person, they're in for vaccinations or they're in for anything else, well child, whatever you're doing, you don't have to ask that question. What's the age? If you ask if they're sexually active, you don't have to ask that question as far as family planning goes. However, what a great way to find out if there's a mandatory reporting issue there. And so I would suggest policy within your agency would be that no matter when they come in, if we ask them if they're sexually active and they say yes, then they need to tell us the age of their partner. I have to have that documented on a family planning client. But that way you have some kind of documentation, because one of the laws that are changing, first of all, I'll tell you real quick what we know for mandatory reporting. Used to be that if you were 16 or under, you as a female, you were not able to consent for sex, or it was implied that it was females, and that anyone over 16 could not have sex with someone under 16. But now it's saying that male or female, any person 16 and under is not legally able to consent for sex. That's a criminal issue, not a mandatory reporting issue. And so we'll talk about that in December. So don't get too freaked out about that right now. The other thing that's changed that we know of is that if they're 16 and under and their partner is 21 or older, that is going to be a mandatory reporting situation. Okay, so it's going to be, we're going to need this, and we're going to need this anyway. We need to know how old the partner is for someone who is 17 or under. And then stay tuned for December for more information, and from us through emails, what we're going to do with that information. The other thing we changed, in case you didn't know it, is Liletta IUD is effective now for under FDA rulings for 5 years. It was always 3 years. It was 5 years. It's now up to 5 years. In fact, I just read something from the FDA on the other day that they've even said that it's proven effective for 6 or more years. But right now, FDA has approved it for 5 years instead of 3 years. And so it's really good. And as a little caveat real quick, if you're, as a 340B provider, if you're providing IUDs, Liletta's only cost $50 and you still get your regular reimbursement. So you have money to be made if you will buy and promote Liletta as an IUD. It's effective for 5 years, and it's going to save you and make you some money. So just FYI. There's a new black box warning on the depot instructions. This came out of Managing Contraceptives, okay, and I'm going to read it to you. It was added in the 2017-18 Managing Contraception. We haven't gotten the 1920. Okay, and it says, weight gain in a woman on depot, a teachable moment, okay? So when you see a patient who is in her first 6 months of using depot and has gained more than 5% of her body weight, you have a teachable moment. Be prepared for that teachable moment and say something, okay? As a security folks say, if you see something, say something. And then it gives you some simple messages to share. We all do counseling on nutrition. And so there they are listed in black and white. But you need now to kind of just kind of keep an eye out on weight gain for our women on depot, and then be ready to provide them some counseling. So that changed. Okay, now let's talk about the challenge, which will take out the rest of my time, which is 2 minutes. Okay.
Maybe you have 7 because of the drill.
Okay, this is big, guys. So the biggest problem with the new rulings, and has caused a major controversy across the United States, and most of it's because HHS and this current regime in Washington is petrified of abortion related to family planning. There's a lot of abortion language in the new rulings. It's stated like 6 times. A grantee may not, we never could provide, but you may not refer a patient, or you cannot counsel, refer, or promote or provide abortion. Okay, so I mean, it's everywhere and it's huge. And so it says the Title 10 project may not perform, promote, refer, or support abortion as a method of family planning. And to that end, they've made another new rule that's going to kind of curl your toes, so get prepared. Okay, it significantly changed pregnancy counseling by a family planning staff. Because Title 10 funds, this is what the law says, because Title 10 funds are intended only for family planning, once a client is medically verified as pregnant, she shall be referred to a healthcare provider for prenatal care. The Title 10 provider may also choose to provide the following counseling or information: non-directive pregnancy counseling when provided by physicians or advanced practice providers. RNs are not listed, okay, and they are not allowed. And that's been through lots of meetings. The new rulings outline counseling to include prenatal care, referrals to social service or adoption agencies, and information about maintaining the health of the mother and the unborn child. Must be provided by an APRN or higher level provider. Okay, what does this mean for RNs working in the family planning clinic or providing pregnancy testing? RNs providing services during a family planning pregnancy test visit cannot provide any pregnancy counseling when the test is positive, okay? As that family planning nurse, you cannot provide counseling of any shape or form, but you can refer all day long. So RN should refer clients for counseling and care. There's an APRN there, of course, refer it to her. Refer clients to a prenatal. You can refer them, say, hey, you might want to go to Dr. So-and-so, or provide a list of prenatal care providers in your locale that provide prenatal care, and let them choose from it. And you can refer clients to other pregnancy resources and provide a list of these resources to clients. So you can provide a list of DCBS or a local pregnancy center or an adoption center, all your prenatal doctors, okay? You can hand them a list. And I think this is going to be our savior in this as local health departments. A family planning RN can refer clients to WIC, HANDS, or the prenatal care program that's provided through MCH at the health department, okay? You can just say, hey, you need to go down the hall to HANDS, or let's get you into the prenatal care program. The staff and our RNs in these programs may provide all the counseling and pregnancy counseling and stuff that they want to, and options counseling and all that kind of stuff. You know, you've got a patient and she's pregnant, and you don't have an APRN there, then you can't provide counseling as that family planning nurse. But you can send her over to HANDS and let them provide the counseling. Okay, when the RN for the family planning portion of the visit is the same RN for the prenatal care program portion of the visit. Man, what do you do about that? Well, you are going to figuratively take off your hat. I'm going to take off my family planning hat, we'll put on my my prenatal care program hat. But on paper, we've got to delineate that, because if we get audited by OPA, that's not cool. So the documentation must clearly delineate the two programs. And so we're revising the PT1, which we're going to present to the NEC next month, about that. It's going to really clearly show this. And that PT1 will only be for the pregnancy test. And then the maternal child health staff, and they're here in case we have questions, are working on a new prenatal care program document or form for counseling clients on prenatal on prenatal care. That will be a different document. So once you sign that family plan, that PT1 that says, okay, she's pregnant, I referred her to prenatal care, even though you end up signing the prenatal care form, you changed hats, you changed roles, or you're a HANDS nurse too, or whatever. But we just need to make sure when you're standing in that family planning role, that we're complying with the new rules. And remember, if an APRN is present, they can provide all the counseling they want to. And I've even allowed, there's an APRN section on the new PT1 that's coming, that's just APRNs only, and it lists all the counseling that they can provide as an APRN. How do you respond to questions? What if a patient says, where do I get an abortion? Okay. You can encourage them to seek prenatal care as soon as possible, and that those folks will explain that to them. You can refer them down the hall, or take off your hat to the program provider. And you can state, and you're allowed, if you can just state that under new federal laws, you're not allowed to provide counseling on pregnancy. Now, y'all, I've talked to hundreds of people across the United States. I've never heard one person say, I love these new rulings, okay? None of us like the new rule. And they're called a gag rule in the news and all that kind of stuff. And so no one likes this, but it's still federal law. And so you can say, I'm bound by federal law, and they won't let me talk to you about this, okay? But, and you can take them to other services. Oh, that wasn't that. That was my last. That was more slide. Okay, and then you can also. Bottom line though is remember that you are the patient advocate, and you should provide the patient with the best information you are able to provide. All right, questions. It is a new day. Any questions? Okay, you want me to read the question? Okay. Since RNs will no longer be able to counsel on prenatal care, will we still be required to provide prenatal multivitamins? Counseling goes along with that. You will not be able to do that in prenatal care, but you can refer them to the prenatal care program, and that'll be documented there.
And hands do that as well.
And hands or WIC, you know, you want to find another mechanism to give them prenatal vitamins. When will the forms be updated? We're working on the forms right now, and we're presenting them to the NEC in November, and I'm thinking hopefully because of this emergency, they will be updated probably pretty quickly within the next month. Any other questions? So as the FPRN, we can't give out prenatal vitamins anymore. No, you can't. But you can refer them to someone down the hall and let them give them out. We recognize that this is a little uncomfortable, and this is a huge uncomfortable pill to swallow. Any other questions? More information to come on the on this, and thank you all, and realize that I don't disrespect anything you do. I understand your pain, and we will be there to work with you through this whole entire process.
Thank you, Benita. Appreciate that. So as I've said before, the audio of this will be on the nursing website. This PowerPoint will be on the nursing website probably sometime next week. I wanted to use this as an opportunity to invite Trina Miller to come up. Since we were talking about maternal child health, we have a new employee in maternal child health that you're going to be seeing a lot of, and I wanted to give an opportunity for the people in the audience to see her face. So Trina.
Hello, I'm Trina Miller, and I have been the perinatal nurse consultant for many years here. And then this year, I am now the maternal mortality review coordinator and childhood-led prevention coordinator. And so we have a new nurse now that has many years of experience with moms and babies. And so her name is Pauline Hayes, and I'll introduce her here.
Hello, it's good to meet everybody. Trying to contact as many of you as I can. If you have any questions, please feel free to email me. And I'm still learning a lot, but I'll be happy to help you.
We are thrilled to have you here, Pauline. Thank you for being here. This is a very exciting time for maternal mortality review. We'll talk about that a little bit in a minute, and so we're just thrilled to have you here. Okay, so now I'm going to get real depth. All right, next up is a face that's very familiar to all of you, and that is Troy Cunningham. How do I make this thing go small? That's terrible. So I have asked Troy to come talk about all things flu. If it's October, it's flu, and we need to hear from Troy. So thank you, Troy, for being here. I'll turn the time over to you. All right.
Well, good morning. I appreciate the opportunity to talk to you about flu this morning. I'm going to be going through this really quick, so my contact information will be at the bottom, and you can feel free to contact me at any time. First, I'm going to tell you the flu vaccine composition this year has been changed, usually is every year. This year they changed the influenza A H1N1 strain and the influenza A H3N2 strain. Last season was the longest flu season on record. We actually had two seasons. We had an H1N1 season. About the time that waned, we went to an H3N2 season. Because of that, the World Health Organization waited an extra month to determine which H3N2 strain was still circulating so they could include it in this year's vaccine to try to get a better match. Hopefully that'll work. But as a result of that manufacturing delay, it meant an extra month trying to get the vaccine to clinicians in the field. We do encourage you to go ahead and promote vaccine as hard as you can. We are worried about it being a bad year, and we have several populations that need to be addressed there. I've gotten in the past 2 weeks a lot of calls about this dosing schedule, and it is confusing. If a child from 6 months to 8 years has had 2 or more doses of flu vaccine before July 1, 2019. If they've had to, they only need 1 dose of vaccine this year. If they have not had 2 doses, they don't know, then they are going to need 2 doses of flu vaccine separated by at least 1 month, at least 28 days. Both of those doses, if they have had 2 doses or more, they do not have to have been within consecutive seasons. So it is confusing, but hopefully when we send out this PowerPoint, you'll have it in front of you. It's also in your CDC guidance for 2019-2020. So flu dosing depends on the type of flu vaccine you're administering. And this is where we've had a lot of questions. The good news is if you're using Flulavol, the dosage is 0.5 mils regardless of age. For children greater than or equal 36 months, it is 0.5 mils for any inactivated flu vaccine. The one tip is that if you use a multi-dose vial and you normally use a 0.5 pre-filled syringe, you're not going to waste anything. But in some of these vaccine presentations, you can use 0.25 mils, and there would be then 0.25 if you're using a pre-filled 0.5, there would be waste there. So from an economical standpoint, you don't want to be wasting vaccine. And this shows the different doses for different vaccines. The Afluria is 0.25 for ages 6 months through 35 months. The Fluarix is 0.5. The Flulavol is 0.5. Fluzone, which is most of our VFC stock that you probably have, is the one that's causing problems. It is 0.25 mils or 0.5. Why they did that, I have no idea. There is no preference expressed for one volume or the other. So it just pretty much depends on the clinician's comfort level and their opinion. So Fluzone is really the only one that you have to worry about because you're going to be checking the package insert, but it is up to the clinician as to 0.25 or 0.5 for Fluzone. All of our vaccines for VFC are now quadrivalent. Groups that need special attention, we have a very low vaccine rate for pregnant women. It's very important that pregnant women are vaccinated because of the immunity that they provide to children up to 6 months old, so that those children who cannot be vaccinated have that immunity through mom. Children, we are seeing already this year, it looks like the biggest group of cases that I'm seeing is ages 1 to 10. And so we really need to get that population improved. The elderly is a particularly hard spot because most of our deaths in Kentucky and nationwide are in the population 65 and older. There is a high dose flu vaccine that has 4 times the flu antigen because as we get older, our immunity wanes. So we want to try to promote that high dose vaccine as much as we can so that we can give them all the advantages they can in getting when they do get the vaccine. Chronic conditions, people with chronic conditions, there's a lot of new studies and literature that's been put out by the CDC that addresses the benefits of flu vaccine in people with those chronic diseases just by simply getting the vaccine. And it really is startling. I'll be presenting that, I'm sure, at some later date. And long-term care facility employees are the lowest vaccinated healthcare professional group in the nation. Particularly the very lowest group is aides, nursing aides, the people that are actually in the patient's faces. And so that really needs to be improved. We've got a big problem there. All healthcare professionals are supposed to be vaccinated in long-term care facilities. It's supposed to be offered, let me correct that. It is best if you can offer it and administer it on the spot. And we are working with the Kentucky Pharmacy Association to try to help improve that by getting some of their volunteers actually into these long-term care facilities to try to administer those vaccines. There'll be more information about that later. We have changed the format of the weekly flu report to hopefully be able to give just a snapshot. You don't have to weed through a bunch of stuff to try to find out the information that you need. Hopefully it's easier to read. It gives you the definition of why we have the activity level that we do, what influenza-like illness definition is. It also gives the different regions, how many deaths we've had in different populations. It gives what we've seen this week and what we've seen so far for the year. It gives you the age ranges of the cases we've seen so far, as well as the types of flu that we're seeing. We still have our map, and the map is really frustrating because the numbers are teeny, teeny, tiny, and it's hard to see how many flu cases you've had. So because of that, this year we're adding a by county list of how many cases have been reported for that week and how many cases your county has had so far in this season, because there's usually a lot of requests for that data by media, by your local health director, for having to report to other people. And so this is, instead of having to contact someone and perhaps wait for that information, it's right there for you as a snapshot. So hopefully that's going to be convenient. If you need anything, just give me a call. We'll figure it out. Here is my contact information if you have any questions. Again, I'm breezing through this whole thing. There was a section on the agenda about getting a hepatitis A outbreak. Amanda Hunt will be doing that, but I'm going to just give you some figures from the vaccine, from the immunization standpoint of that. We have a hepatitis A strike team. So far, they have given 4,735 doses. There have been 98 clinics completed with 18 scheduled. Of note and of great importance is that 21 counties have not responded to the Red Cap survey, and we really do need that completed. So if you can please do that, check and make sure you are one of the counties that's responded. If you are not, please do that for us. According to the Red Cap survey, local health departments have completed 3,292 events, and we definitely appreciate that. The local health departments have given 56,160 doses of vaccine thus far. And with 317, concerning 317 guidance, 317 is given for people that are uninsured, underinsured, or indigent. In this case, they are given for an outbreak. That is an outbreak situation transcends all of that. So when you go out in the field to conduct a clinic, you're already going to a high-risk group. That's pretty much what we're doing right now. Since you are in a high-risk group that we know is part of the outbreak, you do not need to screen as far as that insurance information. If the patient comes into your clinic, however, you do need to screen. And if they come into your clinic for a second shot, they've already been screened, so you don't have to worry about that again. If you have any questions for that, again, give me a call, contact me. Julie Miracle is actually the person that is over the 317 funds, but any of us in immunizations can help you on that. Not only am I the influenza surveillance coordinator, but I am clinical support for any of the other vaccine preventable diseases, as are the other nurses in our branch. So with that, does anybody have any questions?
We'll go ahead and bring Amanda up. Thank you, Troy. I appreciate it. Don't trip and fall. Thank you for that. And we'll have Amanda come up next. So, yeah, we've already gone through those. So we'll go ahead and Troy, I think, is going to stick around a little bit. So if you have Troy questions, go ahead and type those in. And then when Amanda finishes, we can address both of those nursing questions, as well as Amanda's talking, go ahead and type in your questions. So that way, when we get to the end of her presentation, we can all go ahead and go for that. So let's get out of Troy's presentation here, and we'll bring Amanda up. So Amanda is going to tell us about where we are with the Hep A outbreak.
Everybody's tired of hearing about it.
Well, but it's exciting news in a way.
Okay, hi, everybody. Okay, I'm just going to go over a few statistics through October 5th. We have 4,953 total cases now in 114 counties, so 95% of Kentucky counties. 2,387 or 48% hospitalization rate. 61 deaths right now are 1.2%, and 824 genotype 1B of those that are tested. And this information can also be found on the website as well. This is just our curve by month of specimen collection date, our county distribution, incidence rate, and again, this is through October 5th. This is the incident rate just September 5th through October 5th, so basically the last 30 days. Kind of give you an idea there. Risk factors remain the same for the most part, still illicit drug use being the number one with 72%. We do have some information not available for almost 20% of our cases. We don't know risk factors. So, and just a few things we wanted to make you aware of. We are developing an interactive dashboard for the outbreak, and it will be on our webpage. I'm not sure exactly when that will be, but hopefully soon. It's kind of going to be neat. It's a little map of Kentucky, and you can hover over it, and it'll tell you how many cases you have in your county, and so hopefully that will be useful. The Department for Laboratory Services is now performing sequencing in-house, and you may receive some requests to investigate positive results if it's on somebody that was not previously reported, whether the hospital didn't report it or they didn't meet case definition at the time, or what have you. Vital statistics, we will continue to review those bi-weekly to confirm that the reported number of deaths is accurate. And just a few things we wanted to remind you about. The guidance documents are still available on Google Drive or our website. We ask that you continue to submit specimens to DLS for sequencing. Please create notifications even if the case hasn't been interviewed. If you have everything there to make them a case, go ahead and send me that notification, and you can always update the interview portion of that at a later date and just let me know. That's fine. Reminder that the nurse vaccination team, like Troy was talking about, that remains available to assist with vaccine events. And we're still having a lot of trouble getting risk factor information and determining close contacts. So we just ask that you attempt to interview cases as soon as possible in order to determine PDP needs for contacts. And we do understand that this population, since the beginning of the outbreak, has been quite difficult to reach. So we understand that, but we just ask that you do attempt that. Any questions?
So let's see if we've got any questions. Thank you, Amanda, for that review.
I think I've talked to every single person in every health department in Kentucky. So.
Everybody knows Amanda, right? And I went back and just did a quick and dirty count. So it looks like in the last month, we've had 28 cases, which if you can look at that epi curve, that's wonderful, but normally we would have 30 cases in a year in Kentucky. And the other problem is it's up to a 50-day incubation period. So somebody may get exposed today and not show up for that long period of time. So all this PowerPoint will be on the website, so you can go back and look at it. But we do update our outbreak website every Thursday, Friday, Tuesday.
I don't remember. I know we send the report on Tuesday and it's updated fairly soon after
So
that.
the data is fresh on Tuesday, and then we get that on the website. And is in public health, no crisis do we not try to find that silver lining for. The website she's talking about, the interactive website, is something that we wanted to do for ever.
Almost since the beginning of the outbreak.
For even before the outbreak, wanting to make our website much more relevant and much more interactive for people that come to the website. We have a whole new team in our public affairs office who are very interested in doing this. They've looked at other states and how other states are doing things. They've come to us and said, can we do this? Because the reason it's taking so long is we want to put this platform together in such a way that it can be used not only for hepatitis A, but for all other issues, and really modernizing our website. I know y'all have heard this 1,000 times, so have I, but we really do think we're going to make some headway with this new group of folks who are very innovative and want to do some really exciting things on the website. So am I looking in the right place and I'm not seeing any questions? I believe that is correct. So if you have questions, Amanda has given you her information, Troy has given you her information, and we appreciate you coming so much. Thank you. Appreciate it. We'll be happy when we feel like we can take hepatitis A off of our agenda, because that is going to be just nothing but great news for the citizens of Kentucky, and we appreciate your work and all the work of the teams that have worked on this topic. Okay, so we're going to the last presentation, and I decided that I spend all day, every day, working on lots of different issues at the department level, and I wanted to give us some good news. So good news is something that my biggest complaint in our department is we do amazing things, states do amazing things, and we kind of just go right past that and go on to the next thing. And nobody stops and does a little happy dance and say, isn't it wonderful that we've accomplished this or that we're working on this? So that's what I wanted to do. These are things that we're doing in Frankfort and with you, boots on the ground, but it may not be affecting every health department, and I wanted to give you just a breeze through this rather quickly. This is the opioid death rate in Kentucky. That is not an exciting number. No one is proud of those deaths, but if you look at 2018, we did have a 15% reduction in overdose deaths. That translates to about 240 plus families who will not have to bury a family member in the year 2018. I can't tell you the one reason why that has happened. It is a multitude of things. When you've got more than one question, you have more than one answer. And we know, as I said earlier, there is a cascade of things that happen in our substance use disorder crisis. So there are going to be a cascade of answers, and we're approaching it from behavioral health, from public health, from Medicaid, from the criminal justice system, all of those forces working together. That has started to make a dent in what we're seeing. I can't do a big enough happy dance as this slide right here. We started this journey, and when I say we, I always mean the people on the ground in local health departments. In March of 2015, the governor signed into law allowing for legal syringe service programs in the state of Kentucky. The first one opened, that was Louisville, who was 30 miles down the road from Austin, Indiana. They opened their syringe service program in June of 2015. Van Ingram has said 100 times, I thought we'd have 3. I knew Louisville would have one. I thought Northern Kentucky and maybe Lexington. Nobody expected this explosion of red stars that you see on this map. For those of you new, those green counties are counties that were determined by the CDC in 2015 to be vulnerable, more vulnerable or equal vulnerability to Austin, Indiana for the HIV and hepatitis C outbreak that they had. When I do presentations, and since I can't see your face, I can't do that, but when I say Austin, Indiana, I see a lot of blank stares, and I ask for a raise of hands, how many people have heard of Austin, Indiana? And about half of the room has not. So if you don't know about Austin, Indiana, turn to somebody that you're sitting with and have them explain to you what Austin, Indiana is. But what these red stars show you is the grit and the determination and the hard work that local communities have done to get a syringe service program in their community. This is involving getting your Board of Health to agree to this, getting your city government to agree to this, getting your county government to agree to this. So we now, as of today, have 65 operational syringe service programs in 58 counties in the state of Kentucky. The state with the most syringe service programs for years has been New Mexico. They have 64 syringe service programs right now. They've been working on this since the 1990s. We have passed them within the last 2 weeks with 65 programs, and we have 2 counties that have gone through the approval process but are not operational yet, but will up and running. And a shout out to Martin County. They're our last group that just recently got this passed in their local government. So cannot tell you how proud I am to be a Kentuckian when I see this kind of caring and compassion out there. And so that is also, that map and that slide you're seeing there is updated on our website regularly. So if you have any questions, don't hesitate to contact me and we will get you to the right people if you have specific questions. We do have some funding left over from the Behavioral Health Core Grant to help with some startup and some costs for syringe service programs. So let me know, we may have some funding that we can help with there. Naloxone distribution, you folks have been extremely pivotal in getting naloxone out. That change in restrictions was critical. Our mobile harm reduction unit has gone to many of your places. We have gone from the 30-foot trailer to the much smaller harm reduction truck. It is more nimble now, so we can work with you as to where should we park this truck and give out free naloxone and offer HIV and hepatitis C testing. We now, the third bullet is we have helped to purchase 5 mobile units for health departments to use if they want to do some mobile syringe service programs. And we are, again, have some carryover funding that we are now contacting many other health departments about mobile units that have applied for units and didn't get them the first round. We're going to be giving them the second round. I participate and have a single syringe protocol so that if you've got have a pharmacy in your community that wants to dispense naloxone and needs a standing order from a physician and there's not one in your community that will give them that, I can sign that off for them so that patients can come to their pharmacy and say, I need this because of family members. And then we've already talked about syringe service programs and how critical it is that they are handing out this. And we want you to hand this out to people even if they're using meth exclusively, because so much of our meth is also laced with fentanyl. Here's a picture of our truck. I want to get a picture of the truck with the sun shining on it so you can see it better, but it is just a beautiful facility. It doesn't say we are a needle exchange program, come here. It is a very pleasant, in fact, the design was designed by someone in recovery that Linwood Stronecki worked with, and we're proud of that, and the new Sprinter vans that are going to be available to our local health departments. We had a very large hepatitis strategic planning meeting in June, and we are actively working with with providers out throughout the state to come up with a strategic plan for the state of Kentucky. We are also working on a vulnerability index. If you go back to that map I showed you with the green counties, if you think about it, if the CDC produced this in 2015, that means they used 14 and 13 data to produce that. So we, through a grant, have hired an epidemiologist who's working on this vulnerability index right now for Kentucky with much more current data. That map with the green counties is going to change, and I think people are going to be surprised when they realize that currently, as of today, their county may be vulnerable, and it was not listed as vulnerable on that map. So stay tuned for that. That's going to be pivotal as we make policy changes locally. I've already talked about the ending the HIV epidemic, and you will be hearing that as we begin to get funding and make plans of innovative ways we can use that money. CURP, I know Dr. Hoban has talked to you before, but that's the KDAP Income Reinvestment Program. This is funding from the specialty pharmacy that we at DPH help to fund so people with HIV can get their drugs. There is program income, and we are reinvesting that. So we are working in collaboration with the University of Kentucky. Dr. Artis Hoban, who has been our our infectious disease consultant here for several years, is now heading the harm reduction arm of that program. And many of you have already had CURP come to you and talk to you about risk reduction specialists, ways that they can help you pay for hepatitis C testing. There's a lot of money that will be geared toward helping health departments as they ramp up and maybe be able even to expand their syringe service program hours, because they can help with personnel, which is obviously your biggest expense. I do like to tell people, though, that when we did some grant applications for health departments, that one county sent me an application and it didn't have anything for personnel. And so I called the health department director and I said, did you not want to fund your personnel with this money? And he says, oh no, we have 2 retired public health nurses who come back to our health department every Friday afternoon, and they voluntarily conduct our syringe service program because they think it's important for their community. So we have wonderful people out there, but the funding that is from our Ryan White money that we are working with CURP to send out to our health departments is going to be a game changer, I think. The Displaced Opioid Work Group, I'm going to talk about this real quickly. This kind of came to us when there was a pain clinic closed in Louisville. And when the DEA closes a pain clinic, or when a tornado hits a pain clinic, or when a pain clinic provider dies, what happens to those patients? There are a lot of these people that are on opioids. They may not be addicted, but they are certainly dependent on those opioids. What happens to those patients? So we at DPH contacted the Office of the Inspector General, that we contacted the DEA, the CDC now has a task force on this, and this is the group that we pull together periodically, at least quarterly. Every one of those people that are listed on that group have we've got preparedness involved, so Jim House has been helping us with this. Everybody has a work list of things they're to do. We've gotten the DEA is on this workforce, so if they're going to close down a clinic, they will contact us the morning of the closure, so we can get our Casper folks to look at how many patients are in this clinic, what's the average morphine milligram equivalents that these patients, are they prescribing this along with benzodiazepines, all of that kind of information. And then we have a conference call with this group of people and say, go ahead and institute what you're supposed to do. Our list involves making sure that the health departments in those counties know about this, that they're able to stock up on naloxone, that we can bring our mobile unit there if they don't already have a mobile unit. We are going to take our pharmacy detailer that we also I think that's great that we have a pharmacist doing pharmacy detailing, that are going into offices and trying to talk to them about MMEs and the importance of naloxone if you're prescribing high doses of an opioid. We will then take her and kind of get her back into that community and make sure that the providers in that community have the tools that they need. So this is an ongoing project that most of the states that are involved in the CDC work group do not have something like this, and they're impressed that we have the relationships with all of these different organizations to pull this together. These are the people in that group that are in the cabinet, the blue ones are. The rest of these people are advocates or are work groups from other parts of government, and we're excited about that. One of the groups that you see on here is the Poison Control Center. We have been able to fund the Poison Control Center. They now have an opioid crisis hotline. So if you call this hotline number, and you need to post this everywhere you know, this is for people who are actively withdrawing. These are for people who are on opioids. These are for family members. This is for providers. You can call this number. It goes into the Poison Control Center, but it trips over and rings as the opioid crisis line. So whoever picks up that phone knows they're dealing with somebody that has an opioid question. So if a provider says, this person just came to me and says, I was getting this from Dr. So-and-so and now he died and I need your help, what can that provider legally do within the guidelines of regulations to help this person? So we think this is going to be a huge help for the provider community as well as for patients. Other partnerships, we have a partnership with the American Cancer Society and with the University of Louisville. Our immunization program is really trying to push HPV vaccination to our adolescents. We're very low in the state, very low in the nation, and the nation is low. So when you're low of the low group, that's not good. So we're really working to ramp up HPV vaccination. We also in our immunization program have a partnership with the Department for Medicaid Services. We've got a pilot in Louisville, as we were speaking, as Troy said before, getting pregnant women vaccinated, the providers vaccinated and their staff vaccinated. We have a partnership also with the Medicaid Services, the Affinity Project, to try to look at our data on hepatitis C screening and treatment. Our screening is poor in our Medicaid population and our treatment is dismal. Looking at the health inequities, the number of people of color that are being screened and treated is, if there's a word worse than dismal, that's where it is. So this is a partnership where we're trying to work with the new requirements of DMS. The new requirements are you don't have to have all the old requirements. You can still be using it and get treated. You don't have to be abstinent to get treated for hepatitis C. You don't have to have a liver scan and be bad sick before you get treated. You can get treated after 6 months of a positive hepatitis C screening. All things that have broken down barriers for hepatitis C screening and treatment. And put on your calendar, May the 27th to the 28th, we are working in partnership with beautiful Lake Cumberland District Health Department to have another harm reduction summit. This one will be in Somerset, and you will hear more about this, but this is another project that we're working on. Tuesday, between now and then, I will be losing my mind, but this is going to be the launch of the Kentucky Perinatal Quality Collaborative. This has been something that has been of critical value in Kentucky for years, and we were able to get funding to support this. This will be happening at Churchill Downs, and thanks to Jessamine County Health Department for helping us facilitate this project. We would have never gotten it off the ground without their help. But this is allowing all the providers that do women's health and baby health in Kentucky to come to a table with the delivering hospitals and with insurers and say, let's look at the data. What are our data-driven problems in Kentucky for moms and babies, and what evidence-based solutions are out there? And let's all sit down and let's all institute these evidence-based problems as a state, and let's watch our numbers improve. Right now, 50% of our maternal deaths in Kentucky are related to opioids. A maternal death is defined as a woman dying during pregnancy or within the first year after delivery. So half of those are opioid related. It could be she got shot in a drug deal. It could be she was abstinent during her pregnancy, and then because postpartum time is so difficult, she may have used the amount that she used before she got pregnant, and that's just more than her body can tolerate. Or maybe she used a small dose that was laced with fentanyl, or maybe she lost her baby because of something and that child had to go into foster care and may have committed suicide. We have all kinds of tragic stories that our Maternal Mortality Review Committee is looking at. This is going to be a game changer. The Maternal Mortality Review Committee that Trina talked about got up and running in January of this year. So between that starting in January and this happening in October, in my opinion, and I know I tend to be dramatic sometimes, but I think this is going to be a watershed moment for mothers and babies in Kentucky. This Maternal Mortality Review Committee looks at every death, determines if it was preventable or not, and make recommendations how to change that. Up until October, those recommendations went to nobody because we didn't have a PQC. So you will hear more and more about KIPQC as you go along. I did want to give a shout out. Up in the upper left-hand corner is findhelpnowky.org, and if you haven't been there, go there now. There's a mobile app. Can't see you, so if you're working on your phone, I don't know that, but go to findhelpnowky.org and be familiar with that. You may not need it in your workplace, but you may need it at Thanksgiving when you're talking to a family member. This is like Travelocity. Oh, I usually don't say that when this is recorded, but this is like Travelocity for somebody looking for treatment. You put information in there, you hit send, and it's going to show you everything that's available in your area. You can say if you're pregnant, so it will only show you pregnancy facilities. You can say if you're an adolescent, it will only show you that. If you are LGBTQ, you can check that off, so you'll make sure that you are open to area facilities that will respond to your needs. The new website, this Hope and Help, is new. It replaces the Governors Don't Let Them Die. We've decided after 3 years of Don't Let Them Die, now we need to be more hopeful. And so Hope and Help is the name of that new website, and I would encourage you to go to that and see what is available there, but DPH has been involved in that as well. So Hope, expect with confidence. I saw that quote. I've used it at talks. If anything says expect with confidence, Hope, I think it is the people sitting in the chairs right now out there. You come every day with your hope that you are going to make things better for your community, and I can't applaud you and your work enough. Okay, so last minute wrap up, and then we'll be done, and we'll give you some time back to your life. I wanted to be sure that I said again, that we will post all of these PowerPoints, and the audio will be on the nursing website hopefully by next week. That takes some time to get that done, but we will have that up there. We will hopefully by sometime in November have posted the new CSG changes that Benita talked about that are going to be going into family planning. I don't like to do emergency changes like this. I know it is a burden for people in the community, but we will ask our EWD to do like we did with our last changes, and we will have Benita do a snippet kind of summary of what those changes are and why. We'll have the PowerPoint that you can use if you want to use that in your community, or you can also just go on Train and have them watch this so all the nurse leaders will know who has watched that update. We will also post the family planning forms she was talking about in the handbook. We'll have that posted on the nursing website, and then when Women's Health gets their website updated, it'll be posted in both places. I did want to say that one statistic that wasn't mentioned when we were talking about flu, I, as you do, get very tired of people coming to me and saying, well, how effective is the flu vaccine this year? My answer is, well, if you don't take it, it's 100% not effective. So that's the number you want to keep in your head, 100% non-effective if you don't take it. So that's my being public health snarky. The next thing I want to make sure you are aware of is that December the 12th is our next public health nursing webinar. That is a different time than it usually is. That is the second Thursday, not the third Thursday. That gets too close to the holidays, and so historically we have done that the second Thursday of December, so we don't break into everybody's plans. We will also on the website, Deb is not here today, but we will get the public health nursing webinars for 2020. That just doesn't even sound right coming out of my mouth, but we will get that posted on the website, as I know you are making your calendar schedules, and thank you for that suggestion. If you have other questions that either weren't answered or you think of questions that I can forward to people, you're welcome to send those to me, but I think most of the PowerPoints have that person's contact information. You're welcome to contact them as well. So I'm going to look one last time to see if we have any questions. And I don't see any here, if I'm looking correctly. So thank you to everyone for being here and for being a part of this today. We appreciate what you do, and as we move forward, we'll get back to doing CMEs for this. And again, I apologize, that is my fault for not getting that done. But I'm hoping that you will find the information we try to share with you informative and helpful and worth your time. So thank you again, and we'll have Sharon cut us off and Have a good Thursday, everybody.